Guys, thank you all for coming. I'm Dr. Cottingham. I'm a surgeon here at CRMC, and I do lap band operations. I'm also a general surgeon, so I do all types of general surgery operations, such as stomach operations, hernias, gallbladders, etc. And it's a very rewarding thing to help people, but weight loss surgery is rewarding in another way because let's say you take somebody's gallbladder out. You'll see them back maybe one time. They're better, of course, but that might be the last time you see that person. When you do weight loss surgery on someone, you get to know people for a long period of time. You get to see them change, and you get to know people well. And for that reason, it's a very rewarding thing to see the good ways that people change after an operation like that. So I am from Alabama, and I went to medical school in Birmingham and trained part of the time at Caraway for surgery, where I worked with a guy named Henry Laws, who was a pioneer in weight loss surgery. And we did gastric bypasses there, and so that's what I was trained to do originally. And I left Caraway and went to Baylor in Dallas, Texas, and finished up my training out there. And again, we did a lot of gastric bypasses. So I was a gastric bypass surgeon originally when I came back to Alabama and started doing weight loss surgery in Birmingham. And I did gastric bypasses for quite a few years. And then, at first I didn't have a whole lot of faith in the lap band because I was of the mindset, well, you have to cut the stomach in half and you have to have a bypass in order to lose weight with surgery. But then the long-term data started coming out over the years about how people did, 5 years or longer after lap band surgery. And the band also changed. They did some modifications to the band, and the results actually got better through the years. The techniques putting them in, the techniques maintaining the patients, they all improved so that ultimately with the lap band operation, you get a similar weight loss long term than you do with a gastric bypass. So I'm going to get started. I'm going to talk to you a bit about obesity, just to kind of approach the subject, and then we'll get into weight loss, and we'll talk about different weight loss options that are out there for surgery, and then we'll talk about the lap band. I do not do gastric bypasses anymore. It's not that I think it's a bad operation, but it is a drastic operation. It really comes at a major consequence to your human system. It changes you up quite a bit. So you can get similar result with a much less drastic operation to your system. So let's talk about obesity for a moment. Obesity has now been termed a disease by Medicare and Medicaid, and it's associated, of course, with having too much body fat, but there are many other health conditions that go along with obesity. But there's more than just a medical impact of obesity. There's a big psychological side of it. There are social issues that go along with obesity and economic issues as well. There are many different theories as to what causes obesity. And so there's, of course, genetics. People think that your genes will promote obesity in different families. Certain behaviors, of course, among families will promote obesity. Certain issues about socioeconomics and the way people live can promote that. Psychosocial, meaning that certain things can happen to people and the way they choose to cope with these things promotes obesity in that particular person. When we think about it, we're the same piece of biologic machinery that we were back in the Stone Age, human beings. But the society that we live in today is much different, and it does tend to make people larger than it used to be. In previous times, you had lesser amounts of food, and it took a lot more work to get it. So you were burning more calories every day. You were you had less calories coming in, and so for that reason, people were not big generally. But in this day and age, you can have a job where you burn hardly any calories at work, but you make plenty of money, and on your way home from your job, you pass drive-through after drive-through, and it's very easy to get the food that you want. And the food is high-carb food. I mean, it's very calorie-laden food. So in this day and age, it is much easier to get obese than it was in previous times. The doctors measure obesity by using this thing called body mass index down here. You see that? Body mass index takes your weight in kilograms and divides it by your height in meters squared. And so you get a number, and just like a heat index is sort of how hot it seems, body mass index is how obese someone seems. It's not a perfect thing, but it gives us a good idea. We compare that to something called an ideal body weight. Well, this is kind of a lie. An ideal body weight is not really ideal. I am heavier than my ideal body weight. Anybody who's thinking about having a weight loss operation should not have their ideal body weight as their target. Now, the way that number was reached, an insurance company wanted to stratify their clients and decide how much they were going to charge people, and also decide if they were going to even offer certain people insurance or not. And so they came up with a scale of ideal body weights. But it's not necessarily ideal for certain individuals. Like I said, I'm heavier. And so if somebody who needed weight loss surgery reached their ideal body weight, they wouldn't really look good. They probably wouldn't be healthy. And so we don't really use that as our target. But we do want to get a certain percentage of the way there. So that's how we use it. So it's not that it's not useful. We just don't want that to be our goal. Now, obesity is, rated along this body mass index scale. And when you look at a normal weight person, their BMI is between 18 and 25, and anything below that is malnourished. 25 to 30 is when people become overweight. Now, when the body mass index reaches 30 to 35, this is obesity, and some of these people are candidates for weight loss surgery. Now, this is only the lap band weight loss operation. This is not gastric bypass. This is not sleeve. But the lap band only has been approved for some people in this weight category, and it's people who have health conditions associated with their obesity. Now, when the BMI exceeds 35 and goes to 40, that's severe obesity. Again, some of these people are candidates for weight loss surgery, and it's the ones, of course, that have medical conditions associated with their obesity. And in this area, it's not just the lap band, it's gastric bypass and gastric sleeve as well. When the BMI exceeds 40, even if you have no health conditions associated with your obesity, you are a candidate for weight loss surgery. So what is morbid obesity? When you think about those words, basically it means obesity that has reached a degree to where it's now detrimental to your health. Once people reach this category of obesity, their chance of losing a lot of weight and keeping that weight off for a very long period of time is very low. It's definitely less than 5%, maybe closer to 1%. We know that some people do it because, you see people on TV like the Jared guy who works for Subway, does all their commercials. I mean, there are people that have accomplished it. But for every one of those guys, there are almost 100 others who are still trying, and frustrated because they're not having the success that they are looking for. So a question that you should probably have is, am I morbidly obese? Asking yourself. And in your packets there are BMI charts, and you can find your height on one side, your weight on the other side, and you can look at that and you can find out what your body mass index is right now. And so if it's above 40, even if you have no health conditions at all, you're in that category of morbid obesity. If your BMI is greater than 35 and you have some health issues such as heart disease, diabetes, hypertension, obstructive sleep apnea, things like that, then you're also in that category of morbid obesity. Now, obesity in the U.S. Is a major issue. At this time, about 36% of adults aged 20 and over are obese. And at this time also, more adults are overweight than normal. So it's actually abnormal to have a normal weight these days. More than 25 million Americans over the age of 20 suffered from diabetes in 2010, and about 90 to 95% of these had type 2 diabetes, and this is greatly associated with obesity. And to prove that, the data from the CDC showed that nearly 57% of American adults with diabetes were obese in 2010. This slide shows how people became more overweight in this country in the last couple of decades. So you see in 1990, the prevalence of obesity is lower because these colors are lighter. But when you go to 1999, the prevalence of obesity is increasing, and it continues to increase. And so in the last few decades, obesity has actually doubled in the country. This chart looks at body mass index down here and compares it to mortality here, so dying basically. And as long as your BMI is in a normal range, it can go up and it doesn't really affect your mortality. But when your BMI gets abnormal, like to the state of obesity, when it starts to rise, it does cause a change in mortality. And when you get to be morbidly obese, a small increase in your BMI causes a significant increase in your mortality. So obesity has got multiple effects on humans. So we've seen it causes premature death through its comorbid diseases. But of course it also causes disabilities, increases medical costs, reduces quality of life. So there have been studies that have done that showed that a BMI greater than 30, now this is not even morbid obesity, this is just obesity, increases mortality, increases heart disease, strokes, and diabetes. It's also been seen that a morbidly obese adult has a 33% chance of living to age 65 as that of a normal weight person. Why is that? It is all the health conditions that are harmful to us that are associated with obesity. So for instance, type 2 diabetes, high blood pressure, coronary artery disease, strokes, high cholesterol, arthritis. You may think about arthritis and say, how could that shorten your lifespan? That's just an inflamed joint. When it gets too painful to get out and exercise, just to walk around, you become a sedentary person. And the more sedentary you are, the more your health will decline. Other things too, sleep apnea, acid reflux, lots of health conditions are associated with obesity. Many others, even certain types of cancers. I'm not going to go through every one of them, but obesity does affect us in a lot of ways. But there's not only a medical side, there's a psychological side as well. Not every obese person is depressed, but there are trends toward depression, low self-esteem, feeling socially isolated, being uncomfortable sometimes in public, and it can cause intimacy issues, libido issues, and physically, obesity can affect you by making it more difficult to do things that a lot of people don't have to think about. Going to the movies, riding on an airplane or on a bus. Sometimes people are a certain size and they require a special seat belt. In areas where turnstiles are common, such as big cities with transit systems, lots of times it can be more difficult to get through a turnstile. One thing that I hear with people in the South, of course, is they want to be able to play with their kids, and it's more difficult to be as active as you want with your kids, do the things you want to do. It's more difficult to stay clean and find clothes, that you feel like you look really good and stylish in. Economically, obesity does have a significant impact on the country. When you factor in medical bills associated with all the health conditions, lost days at work, weight loss products, weight loss programs that people invest in. It's a big price tag associated with it. So that's basically about 10 minutes of talk to reach this point. Should we do something medically about obesity? And so, yeah, we should. So what should we try at first? Well, of course, diet and exercise. You're all very familiar with that. Decrease your calories coming in, increase your calories burning. And most everybody, by the time they see me, have tried that many times. Behavior modification is a broad term, but it just means changing your daily behaviors in a way that will help you reach your end goal. So in terms of obesity, we're talking about maybe eating off of a smaller plate, maybe not eating in front of the television or at your desk at work or driving down the road. So just little things you can do to decrease your calorie intake. Other things that are tried, weight loss programs, of course, appetite suppressants, and some other issues that are a little bit off the mainstream, counseling, hypnosis. And in the past, even jaw wiring was tried at one time, and it was found to have about a 100% failure rate because it does take something up here to help you lose weight for the long term. And you can wire somebody's jaw shut, and if they don't have it going on up here, while their jaw is wired shut, they can get a straw in there with a milkshake or Milo sweet tea or whatever, and they can get the calories in. And then who's going to leave their jaw wired shut forever? Nobody. So when it comes off, they are ready to go. And so it's not just a physical thing. You have to have a psychological motivation as well. So what can we expect if we do it right, if we diet, we exercise? Well, the National Institute of Health says that if you do this for 6 months, you diet, you exercise, what can you expect? You can expect about a 10% change in your weight. And if you get that in 6 months, you're actually doing pretty well. So I like to think about, a lady, maybe this lady's ideal body weight, like I told you, is 120, and she happens to weigh 320. So if this lady loses 10% of her weight, she's lost, roughly 32 pounds. She's still about 288, I think, if I'm doing the math right. She's going to feel better at that weight than she did before. Her diabetes might be a little bit better, but she still weighs 288, and most people are wanting more than that. A very low-calorie diet is a diet that contains 800 calories. People try this. They do lose weight at first, but what most people tend to do with just dieting is regaining that weight, as you see here, and over time getting right back where they were before. Sticking to 800 calories on your own is very tough because you can go to Starbucks and get a drink with 800 calories in it. So you really have to be well behaved and disciplined. This slide just basically shows the story of weight loss programs like Weight Watchers and so forth. You got 100% of people starting on day one. Well, if all these people kept going, the results might be pretty good. But what happens is, in just a few weeks, less than half the people are still going. And every few weeks, less and less attendance is present. So it's very important to have this in mind. If you are going to do something temporarily to help you lose weight, then your results are going to be temporary. So, what we need is something that we can stick with. Maybe not even something so drastic, but you need something that you can do from now on because you're not going to get any lasting, results for the rest of your life with something that you're going to do for, 2 weeks or even 5 weeks or 6 weeks. Now, this slide is interesting, talks about exercise. I find it interesting to know that if I want to lose a pound, I've got to burn 3,800 calories. And so, there are people out there that need to lose 100 pounds. Well, in terms of calories, that's 380,000 calories they need to burn to get there. So when you exercise strenuously, depending on who you are, what you're doing, you burn about 10 calories a minute. So average half-hour workout, that's about 300 calories. That's very good. But let's say you go to the gym, you've worked out, you're all sweaty, you're ready to go home, but you get that Gatorade, you get that power bar, protein bar, whatever. Now, I'm being kind here. It could be a Mountain Dew and a candy bar, but that's going to completely refill you with those calories that you burn during that workout. So this slide helps you understand that, even though exercise is good, it makes you feel better, it increases your metabolism. When you put on muscle is the most metabolically active tissue that we have in our body. So if you can put on some muscle, even while you're asleep, you're burning more calories than you would otherwise. But exercise really just helps you maintain weight loss. What really, for the people that need to lose like 100 pounds, calorie restriction is how they really accomplish that weight loss. And that brings us to surgery. Is surgery a good treatment? Surgery is a pretty good treatment. Surgery requires that you go to an operating room and go to sleep and somebody operates on you. And is that perfect? No, it's not perfect. But because surgery is the only thing that we have that routinely works for morbid obesity, then that makes it a pretty good treatment. What it's able to do is, as you see right here, it takes the calories that are coming into your body every day, it makes them less than the calories your body's burning every day. And, if you're doing that on your own, there's a word for that. That's starvation, and that's not very pleasant. To give your body less than it wants to stay the same, that's uncomfortable. But when you can get your calories coming in less than the calories you're burning, that's when you're going to get weight loss. Now, at this point of the talk, this is one of the most important things I'm going to tell you all night, so listen to this. The goal of every weight loss operation is to assist in reducing your daily calorie intake. Assist is very important because nobody needs to think that they are going to have a weight loss operation that is going to do it for them. Their success is not going to be that great if they have that mindset. If somebody thinks to themselves, I'm going to get a lap band to keep me from overeating all the time. I mean, yes, it helps, but if you're thinking you're going to try to overeat and it's up to that band to keep you from failing, that's not the way to think about it. That band is going to help you succeed. That's how you need to be thinking about this. But what surgery does, it makes it possible for the patient to control their weight for the first time in their life. So, many of you guys, I'm sure, have dieted, exercised, you lost some weight, you were rewarded for a while, but then it came back. You didn't get the long-term reward you're looking for. You're still in control. You're still the one that needs to take the responsibility, but this helps you get that long-term reward that you're looking for that you're unable to get on your own. It's not to keep you from failing. It's not to keep you from doing self-destructive behaviors. It's to help you succeed. Now, we are not putting lap bands in people so that they can get skinny. People go to the plastic surgeon to get skinny. We want people to be healthier. We want people to have a better quality of life, live longer. Now, a lot of times people do look better when they lose a lot of weight, and that's just a nice side effect, but that's not why we're doing this. Surgery should not be considered a quick fix. It's a tool, like I said, to help you lose weight. It's not for people who are obese. is for people who are clinically severely obese or morbidly obese. And our goal, again, is not to get skinny. Our goal is to be more healthy. So what's the criteria for surgery? Again, if you've got no health conditions whatsoever, it's a BMI of 40. If your BMI is only 35, if you've got some health conditions associated with obesity, then you are a candidate for an operation. History of trying to lose weight in the past and not being able to do it. Also, it's stressful to do something, that's going to change the way that you eat. That's one of the most fundamental things in your life. So you really have to have it together psychologically in the sense that you don't need to have a substance abuse issue, have psychosis issues, or uncontrolled depression. A lot of people have some level of depression. They may take a little medicine for depression. That's very common. As long as it's controlled, that's not what I'm talking about right here. Now we're going to talk about some surgical options. And the malabsorptive option, which I'm not going to spend a lot of time on, but basically you eat, it passes through and doesn't get absorbed. There's a restrictive option, which is you can't seem to get the food in. Once the food is in, it's absorbed appropriately. It's absorbed like normal. The vertical banded gastroplasty I meant just for completeness. We don't do that anymore. The lap band is a restrictive operation. A combined operation is one that provides malabsorption and restriction, and that's the gastric bypass. Just to show you the gastric bypass, the stomach here, as you can see, is cut into two pieces. The intestines are cut into two pieces. The lower part of that intestine is brought up to reconnect to the small stomach, and the top part is brought down lower. So the food comes in like this. It does require stapling, cutting, 2 new connections. You can't look at this part of your stomach anymore with an endoscope if you go to the GI doctor. This operation is functionally reversible, but it's very difficult to do so. It's a complex operation in the first place. To reverse it is more complex and more hazardous. There are some good things about it. It's been done for a long time in this country, and we know what to expect. It does provide good weight loss. It's done minimally invasive, and there are minimal diet restrictions. But the potential disadvantages are, because of the cutting, the stapling, and the reconnecting, you can have many more complications that you don't have in an operation where you don't have to do that, such as bleeding, leakage, strictures, and so forth. There's something called dumping syndrome, which is very uncomfortable when you eat certain types of foods. Because a part of your GI tract is bypassed, a lot of the nutrient absorption that you would get from those areas that are bypassed, that can cause potential nutrient deficiencies. It's not adjustable. Once it's done, it's done. And the mortality rate is higher than lap band operations. Like I said, it's a complex operation. It's very difficult to reverse. There's a newer operation called the gastric sleeve. And in this operation, most of the stomach is cut out, leaving a small tube of stomach here that your food will pass through. The advantages to this is the weight loss results are successful, and it can be done from a minimally invasive approach, a laparoscopic approach. Potential disadvantages are the cutting and the stapling again. This does require that. So you can have bleeding, you can have leakage, you can have strictures. Because a large portion of the stomach is removed, this is completely irreversible. Once it's done, it's done. You get more complications than with lap band surgery. It's not adjustable either, and the mortality rate again is higher. So let's think about if we had an ideal weight loss operation, which we don't, but if we had an ideal bariatric operation, it would be minimally invasive, it would be safe, and it would work. It would help control your weight, it would help control your medical problems, make your life better. It would work over a long period of time, and it wouldn't require reoperations or revisions. Side effects would be minimal, It'd be very simple, so it could be done the same way time after time. And adjustable. That's great if you can adjust it, because everybody's different from each other. And even one person, you know, that 330-pound lady I mentioned before, if she loses 50 pounds, she's different than she was at 330, you know. And reversibility, that's also, you know, if we had a perfect operation, that would be key. Well, the lap band operation, although it's not a perfect operation, it does satisfy a lot of those requirements of an ideal procedure. So what I'm going to do, I'm going to let you have a break from me talking for a minute, which I'm sure is very welcome. I got a very brief video for you. It can do a lot better than I can in just a couple of minutes about showing you what the lap band is like, what it's about. So here we go.
The lap band adjustable gastric banding system is a tool to help you achieve sustained weight loss by limiting how much you can eat, reducing your appetite, and slowing digestion. The lap band is an adjustable silicone ring that connects to an access port by thin tubing. The lap band AP system is the third and latest generation lap band system. Its design and performance are the result of 7 years of U.S. experience, as well as countless collaborations with surgeons across the country. When placed around your stomach, the lap band AP system immediately provides a fit tailored to your anatomy, which allows for optimized weight loss right from the start. Omniform inflation, which provides 360 degrees of pressure evenly delivered throughout the band for complete stomach coverage. Soft and flexible pre-curved individual sections that help minimize the potential for leaks from creases or folds. The highest fill volume available, which leads to greater flexibility and customized adjustments. Available in 2 sizes to accommodate different anatomy and individual needs. The lap band system surgery is usually performed laparoscopically. The device is inserted through one of 5 or 6 small incisions and is wrapped around the upper part of the stomach. This creates a small upper stomach pouch and a narrowed outlet between the new upper pouch and lower stomach. The lap band system is connected by a tube to an access port fixed to the muscle wall just below the skin of your abdomen. Using a fine needle, saline solution can be added or removed from the band to find the right level of restriction. As saline inflates the inner surface of the lap band system, the stomach outlet becomes smaller. This helps reduce the amount of food you eat and slows the emptying of food from the upper to the lower part of the stomach. This helps you feel full sooner and stay full longer. The lap band system is the #1 adjustable gastric band sold worldwide.
Okay. So it is silicone, just like other implants that are meant to stay in indefinitely. It's not like we put it in and we want to take it out at a certain time. We expect it to be there indefinitely. It's a fairly quick operation, an hour to an hour and a half usually. Most people do go home the same day of the operation, and it's a laparoscopic operation. It's not terribly invasive, so a lot of people can get back to work in a week, sometimes even less. And we gradually tighten this thing so that, like an hourglass, it controls the flow of food through your stomach, sort of like an hourglass controls the flow of sand through it. And so, but it's an adjustable hourglass, so you can adjust it to where the food goes straight through, or you can adjust it to where nothing goes through. So of course we want it to be where the food goes through slowly so that it keeps you feeling full and you can't eat as much. Now let's compare the lap band with the gastric bypass and the sleeve as far as how well does it work. And what I've got for you here is 1 year results and then long-term results, which is 5 years or more. And so at 1 year, the average person after a lap band loses 49.6% of their excess weight. So that's about 50% of their excess weight. What is excess weight? Okay, you remember the ideal body weight, which I told you should not be your target? Well, you take your actual weight and you subtract from that your ideal body weight and you get your excess weight. So the 320-pound lady who's supposed to be 120 pounds, she's got 200 extra pounds. So average for that person would be about 100 pounds in a year. And average, of course, means some people did better, some people didn't do as good, but that's just average. 1 year after a gastric bypass, it's a little better, 67% of excess weight. And average after the sleeve gastrectomy, it varies. Different reports said 46 to 83%, depending on the surgeon. Okay, long term. We don't just want weight loss for 1 year. We want weight loss going on throughout the years. And so what happens 5 years or longer? Well, the average weight loss for the lap band continues to go up. So people over time are continuing to lose a bit more weight with the lap band. And so the average weight loss 5 years or more is 55%. What happens with gastric bypasses is after they lose all that weight initially, they usually will regain some. They don't regain it all, but they regain some. And so the long-term results for gastric bypass come down some to about 58%, which is a little better than the lap band. And I don't have good long-term data for the sleeve gastrectomy for you because it has not been around for a really long time. But here's an important point about this 3% difference here. What kind of weight do you want to lose? It would be very nice if you could lose all fat, right, and just keep everything else. Well, you can't do that. Even if you diet and exercise on your own with no surgery, and let's say you lose 100 pounds, about 17 pounds of that is going to be lean body mass, so muscle and so forth. You can't lose 100% fat. Well, when you lose weight with a lap band, it's still about 17% because there's not a bypass. It's very similar to doing it all on your own. Well, when you lose weight with a gastric bypass, if you lose 100 pounds, you may lose over 30 pounds of lean body mass. So when you think about that 3% difference and the fact that you had to give up some lean body mass to get that, that makes that difference less significant for the long term. It's still a good operation. It still has helped many, many people, and it's changed a lot of lives. But it's drastic, so it has some effects like that. Let's talk about safety. The first thing is mortality. This is people dying from surgery. So has anybody ever died from a lap band? They have. How often does it happen? About 1 in 10,000. So mortality rate for lap band is about 0.05%, 1 in 10,000. That's approaching the mortality rate for just getting your gallbladder taken out, That's a very low mortality rate. With a gastric bypass, the mortality rate is more like 5 in 1,000, so 0.5%, which is, of course, 10 times. And it's nearly that for sleeve gastrectomy, almost 4 in 1,000. Early complications, meaning bad things happening, not death, but other bad things happening within 30 days of surgery, 1.5%. So compare that to gastric bypass, up to 25%. 25% is high, but somebody's reported it before. And similar with the sleeve gastrectomy. So what complications can you have? Well, I'll tell you the ones that I've had, and most every surgeon that does lap band surgery has had them all. I have not had anybody die. I have not had anybody require a blood transfusion, although people have bled a little during surgery. It's been controlled, and nobody's ever bled enough to need blood. I've never had anybody critically ill after a lap band operation. I have had some bands go on, and they ended up being too tight, and the person needed needed to have either the band exchanged for another one or have a little bit of fat removed from around the stomach so it wouldn't be too tight. I've had other people that seemed too tight, but I drew a little more fluid out, and they were fine. So that's one possible complication. Another possible complication is the band slipping down on the stomach, or the stomach slipping up through the band. That happens just a couple of times in 100. If it happens, it's not really an emergency, but the person cannot tolerate food well. We take the fluid out of the band. They will have to have the band taken off and put back on the appropriate way. I hope I'm not talking it up, but I haven't had a slippage in a couple of years here. So they're actually very uncommon, and the new design of the band made slippages more uncommon. And maybe somebody could, Brittany, if you or Donna could pass that band around so people can actually see what it looks like. Another possible complication is erosion, the band actually eroding into the stomach. There's a very low chance of this, maybe 1 in 100, extremely uncommon. It doesn't happen quickly. It happens very slowly. So you think about something eroding into the stomach, you would think about maybe leakage from the stomach and it being a life-threatening complication. It's not. It happens so slow that everything is sealed off as it occurs, kind of like if you've ever seen a tree with a chain growing into the tree. That happens so slowly. So that's not a life-threatening complication either. That's something that you can plan and deal with. But when you fix that, you have a hole in the stomach and you cannot put a lap band back on those people. So that's what can happen with the band itself. What about the port that goes on your abdomen? Well, a port can get infected and have to come out. And I've had one patient have a port infection. And that's the only patient I've ever had with any type of wound infection after a lap band operation. We take a lot of safeguards to prevent infection, and fortunately it works very well. That particular person was a healthcare worker, and I don't know if that contributed to that infection or not, but probably did. Other things that can happen with the port, if the stitches come out of the muscle, the port can flip over, in which case your needle to do the adjustments cannot go in to adjust it. So that would have to be positioned back correctly and sewed back down so the needle could go in. It has been years since I've had that one. If the port begins to leak, the band won't hold the fluid in, so when you do an adjustment, it does not stay adjusted like you want it. I have had some leaky ports, none within the last few years. We've been very fortunate here for the last few years here at Coleman, and we've had very low complications. That is that hits the high points on the complications that you can have with a lap band. With a gastric bypass, you have to worry about things like hernias forming, ulcers, where the bowel is connected to the stomach from the increased acid, bowel obstructions occurring later on, internal hernias, vitamin deficiencies, bleeding, so forth. Sleeve gastrectomy, with that little tube with the stomach coming down, we worry that it can stretch over time and hold more food so that people might regain their weight later. The staple lines coming undone and leaking, bleeding, or becoming too tight, stricturing and scarring occurring. And that's it for complications. So with a lap band, the potential advantages are it's much safer because you are not entering the GI tract. You get to keep your stomach intact, you get to keep your intestines intact. We're just putting a band on your stomach to make it, like I said, like an hourglass. It is adjustable, so it changes with you as you're losing weight. It is being adjusted to fit you. It's the least invasive option that we have. We don't have to cut, staple, or reroute anything. It's totally reversible. So we don't plan on reversing this, but if for some reason you did have it reversed, you would have a few scars on your skin, but that would be basically it. Functionally, you'd be just like you were before. No leaks. I've never had a leak after a lap band operation. Very low risk of malnutrition. It does make you feel full, and it's a quick operation, and you're in and out of the hospital pretty quick. Potential disadvantages. Compared to a gastric bypass, the wait initially is a little bit slower. We are gradually adjusting this thing. And another thing is, you know, follow-up is important with this. It's all important. If you have a lap band and you decide you don't want to come see the doctor anymore, your results will stink because that adjustment is key. If you were to get a gastric bypass and say, I don't like my doctor, I'm not going back, then you will continue to lose some weight probably. But this thing's got to be adjusted at first. Now, it doesn't have to be adjusted forever. You reach a point to where it fits you and it's stable. But you got to come back and let that happen. So the way it generally occurs is you come in the morning of surgery, get admitted to the hospital, you get an IV, of course. You have just a standard general anesthetic in the operating room, so you're totally asleep and unaware. You get antibiotics. You get medicine to prevent blood clots in the legs, which is another serious complication of weight loss surgery. By this time, most everybody is going home day of surgery. It's been years since I've actually kept somebody in the hospital overnight. Well, I can't say that. I had one lady not too long ago that did have some breathing issues. She had bad sleep apnea. She did not bring her machine to the hospital with her. Her oxygen was not high enough the evening of surgery to go home, so she stayed till the anesthetic got out of her system. She went home subsequently. Post-operatively, you know, I give people some anti-inflammatories before surgery. I inject a lot of local anesthetic during the procedure in the areas that I work. I do prescribe narcotics afterwards, and most people need them for a couple of days. Most people get 4 or 5 incisions, and these are sewed up with stitches that dissolve, so there's no staples to remove, no stitches to remove, Steri-strips over the skin. Activity-wise, people have this operation, they go home that day, they get up and move around even that day. They don't go home and stay in bed all day. Very important to get up and move. That helps recovery immensely. What do you eat after this operation? Well, when you first wake up, you can have clear liquids. When you go home, you can have liquids for 1 week. You have to be on a liquid diet. I want this thing to heal. I don't want it to be tested with a hamburger, you know, the week that you had it done. And then we gradually thicken that up to solid food over the course of a month. And at 1 month, you're on regular food that you really have to chew, you know, to get down. And that helps us decide if you need a fill or not, you know, right at that month. This thing is made out of silicone, like I said. It's got a hollow band inside that we fill up with saline. And the adjustments make that tighter or looser on your stomach. And it's done very quickly in the office. This is an older style band. It doesn't have the grooves in it like the newer band, but it's good to show you that an unfilled band is wide open and your food will zip straight through it. When you've got stomach inside of this too, this is probably completely shut off. So very minor adjustments have a very major effect. Adjustability is the reason this works. If we could not adjust this thing, it would not have a good success rate at all. So I adjust people very freely. It's not a big deal. Come in and just in a few seconds you get an adjustment. Sometimes I adjust people during the first year almost every time they come in. I've had other people go 7 months before they needed an adjustment. So everybody's an individual here. But the port is placed on the muscle. It's under the skin, under the fat. So That port is fixed onto that muscle, and so I can feel that. I can get my needle into it. Sometimes radiology is used to locate the port if somebody is so big I can't feel it. It's been years since I've required that. If a band is adjusted correctly, as one patient told me, you're just going to lose weight. How much? It varies person to person, but maybe in the beginning 1.5 pounds to 2 pounds a week. You should be able to eat most solid food. Everybody with a lap band that's adjusted right has some things that just don't go down right. And it may vary a little bit person to person, but you know, thick, tough bread, that's probably on everybody's list. Tough meat, anything you chew up and it goes down in a big ball is going to hit that hourglass and it's going to stop. And it might eventually go through, but it might have to come back up. So although I do have some patients that have never vomited or had any reflux after this operation, most everybody has encountered something that doesn't go down very well. You've got to chew your food very well. If you take a big bite of something, you don't chew it up, it's going to go down, it's going to hit that hole, and it's going to be a problem. So you have to take small bites and chew. So there's a little bit of learning involved on how to eat afterwards. You should be able to eat a small meal comfortably. Liquids between meals will shoot straight through this thing. They don't sit up on top of the band and make you feel full. So that means you can drink what you need to stay alive after this. But the warning is, if you like drinking sweet tea or milkshakes, there's a problem, because that's a lot of calories going in that are not making you feel full, and that will cause you to fail on your weight loss. So that's the mental part of it. It's got to be up to you to say, if I'm going to have an operation to lose weight, I'm not going to drink sweet tea all day and make myself fail, or even regular sodas, milkshakes, whatever. What you drink all day needs to be something that does not really have a significant amount of calories in it. Fortunately, there are a lot of options available right now. So if somebody comes in, they're not losing enough weight, or they feel like they're eating too much, I give them an adjustment. I put a little fill in there. Sometimes people come in, and for some reason they've started having some reflux, or maybe even some vomiting sometimes. If they feel like they're not eating enough, they're having to go to a certain type of food they know is not good for them because that's the only thing they can get down. These people need to have a little bit of fluid taken out of the band, and that's no big deal either. We want people to be here in this green zone where you're not real hungry between meals. Your weight loss is good, you're happy with it, and you're satisfied, in between meals. If you're hungry all the time and you're looking for food and you're not losing enough weight, you need to have some fluid added. And if, like I said, it's too tight, you're making poor food choices, you're regurgitating, you're having reflux, you're coughing at night when you lay down to go to sleep, then you need to have a little bit of fluid taken out. So everybody who has this operation will see a dietitian who will train you very well and make you very comfortable with what you need to eat after surgery. So I'm not going to go into a great amount of detail here. Some guidelines, though: 3 meals a day. Just because your meals are small does not mean you get to have 6. Eat slowly, chew very well. When you start to feel full, you need to stop. It's like I said, this band is there to help you, and it helps you by telling you when you're getting full. It's not there to make you vomit when you eat too much, okay? So you listen for it, and it will tell you when to slow down, when to stop. Best if you don't drink while you eat, because you need the nutrition from that solid food. You don't need to fill your stomach up with liquid too while you're eating. But drink as much as you want to between meals. Avoid really tough fibrous food like that, and also exercise some every day is very important. And exercising right now might seem crazy and very difficult, but I've had people that were morbidly obese, they had this operation, lose weight, and start running in 5Ks, even 10Ks. And that patient that I told you that had the wound infection, my only one that ever had a wound infection, that lady has done a half marathon. And this is somebody who qualified for a lap band operation. So these are some of my patients just to show you, how people can do after this lap band operation. This was the first lady I did in Coleman. She's done extremely well. Even some famous people you may have heard of have had this operation. This slide just shows the gastric bypass weight loss versus the lap band weight loss. Gastric bypass, lose some quickly, then regain some, and the lap band just gradually moving to a similar result. The change in body mass index afterwards, let's say we start at an average of 45, coming down to an average of about 31. Is that a normal BMI? No. But when you compare that, you think about those people that did have a BMI of 45, that's a great change for those people. A lot of people who want to have a lap band have some health conditions that they want to get rid of as well. And it's very important to understand that you don't need a gastric bypass or a sleeve to have improvement with those health conditions. These studies were done on people who had lap band operations, and asthma in people who lost weight with lap bands improved. These people were better or cured by their asthma 93% of the time. Type 2 diabetes after lap band surgery improved or cured 90% of the time. Obstructive sleep apnea improved or cured 93% of the time. Gastroesophageal reflux disease 90% of the time. And high blood pressure, not quite as good, but still good, 79% of the time. So you've got a lot of people getting off medicines, getting off of CPAP machines for their sleep apnea. So it has a wonderful effect on people's health. What is failure? Failure is if you don't lose half of your extra weight. So that lady that I keep going back to, 320-pounder, if she did not lose 100 pounds, she would be considered a failure, even if she lost 90. So if you lose 90 pounds, that's a big improvement. You're going to feel much better and be much different, but you got to lose 50% just for that threshold. And that's just, that doesn't mean personally you can't consider yourself a success, but we don't consider the operation to be fully successful. Well, with lap band surgery, failure occurs 15% of the time. With gastric bypass, it's 13% of the time. So it's not a great difference there. And like I said, somebody who's lost 90 pounds can still be considered a failure. But that just goes to show that not everybody loses that full amount of weight. You have some people that do great, some people that don't do quite as well. With the serious complications that you can have with the other operations like leaks, blood clots, wound infections, and so forth, you hardly ever get those with lap band surgery. Long-term complications related to vitamin deficiencies, I really have not seen those with lap band because there's not a bypass. Everything is absorbed appropriately. So, speaking in terms of the operation's difficulty, time in the operating room, risk, success with weight loss, and nutritional risk, the lap band scores quite well rated against the other ones. And the truth about any weight loss operation is it is generally successful. They're not perfect, like I said. They do require that the people having them know, in fact, what the operation is about, what's expected of them. A crime would be to do a weight loss operation on somebody who's not educated about a weight loss operation and then have a poor success. That would be the surgeon's fault. Now, if a patient knows what to do and they don't do it, then that's their fault. The patient should be selected appropriately, taught what to do, and they should have access to a multidisciplinary program, which is one great thing about CRMC. You get me, But you don't just get me to do your operation and your fills and to give you a pep talk every time you come back. You also see a dietitian to help you along. You also will see a physical therapist to help get you started with something that you can do to increase your physical activity. Later on, you probably won't need them because you'll be much more active and feel better. Some operations may need to be reversed or revised, like I told you, but we have been doing very well. It's been a long time since we've had to reoperate on anyone around here. The overwhelming majority of patients are very happy that they did this, and they're very happy with their success. So to conclude, obesity, it's now considered a disease, and surgery is the only thing that routinely works to treat this disease. The lap band is one of the options available, and it's the safest option. It's very gentle, it does work, and it's adjustable if necessary, reversible, and it should be considered for the right people. Most insurance companies cover lap band operations now. Some insurance companies don't cover it. Some insurance companies have exclusions, and so financing is available. The lump sum payment originally was $16,000 here, which I've not changed that on my slide yet. It's been decreased to $14,000. If you were to have to pay cash, that would cover me for an entire year, every visit, no matter how many times you had to come back. If you needed me to reoperate on you, it would be included in that. It covers the anesthesiologist to put you to sleep for your lap band operation, and it covers the hospital cost for that first operation.
Medicare only covers certain institutions, CRMC, a certain institution.
That has actually changed not too long ago, and we are now doing Medicare at CRMC. Some insurance companies, such as Blue Cross Blue Shield, requires that you jump through some hoops first, such as a 6-month physician-supervised diet with monthly visits. They want documentation showing that your doctor has been watching you do a low-calorie diet, increased physical activity, and behavior modification every time. They also want you to see a dietitian. Not only do they want that, they want your weight for the last 3 years in your doctor's note showing that you didn't just become morbidly obese, but you've been morbidly obese for the last 3 years. If you ask me, it doesn't matter how long you've been morbidly obese, you're there, you need help, but they want you to be morbidly obese for 3 years. An example of somebody going through this journey to get a lap band, they find themselves here just like you tonight. Their doctor sent them, or a friend encouraged them to go, or they saw an ad or saw us online or something. And so they thought it looked good. They thought it might be for them. They came into my office for a consultation. So over here you have Donna and Brittany. This is my office staff. If you would like to call them for an appointment tomorrow, they'll be happy to get you in. So once they come in for an office consultation, we get their records for their height and their weight for the last 3 years, and if they have to, they embark on that 6-month physician-supervised diet. Once we get that all documented and put together, we send that to the insurance company for approval. Once people are approved, then they will be referred to the dietitian for instruction on the diet after surgery, the exercise therapist to give them a game plan on physical activity, and also a psychologist, because as I mentioned before, this can be stressful to have to learn how to eat again, and we just need to make sure that people are ready to cope with that. And if somebody has uncontrolled depression or some other issues, substance abuse and so forth, they might need to get that addressed first. After all that's done, you come back and see me one more time before surgery to answer any last-minute questions, check and make sure no medical issues have changed. There is a short diet that must be done before a lap band operation. If you've ever cheated on a diet in your life, please don't cheat on this one, because this is a low-fat, low-carb diet, high protein for 1 week before surgery. Big people have got big livers. And that liver is right in my way when I'm doing this operation. So you can do this diet for a week and your liver will actually shrink and make it easier for me to keep up out of the way. And so you do not want me struggling during your operation, so please stick to this diet plan. You have your operation. You come back 1 week after surgery for a post-op visit, and that's just a checkup. Then you come back 1 month after surgery, and that's when we might do your first adjustment. People come back for adjustments every 4 to 6 weeks during that first year. After that first year, I recommend every 6 months for the second year, and after the second year, I recommend every year checkup thereafter. A lot of people don't do that. They get a certain distance away, and I guess they feel comfortable with their success, but I do recommend this. And I will say that the people that come back to see me are going to do better than the ones that don't naturally, and you can understand why that is. If you are spending less money on food, if you are spending less money on medicines, it's probably going to help, with the affordability of this operation. Also, there have been people who paid for this operation themselves say to their accountant, I spent all this money on a lap band operation. It was medically necessary, and some people have gotten a tax refund for that. So hopefully everybody in here has insurance to help them. But if you're thinking about paying cash, then that's might be an incentive which might make it more affordable. But ultimately, this is a safe operation, effective. Hopefully your insurance company will take care of things for you. If not, see if you qualify. See if you can budget payments or whatever. I've got a quick video that I'm going to show you, just to show you how simple this is. This is not me operating. This is a video that came from the company. And this is probably the thinnest person that ever had a lap band operation. But it's good just to show you what's going on. You got the spleen here. You got your diaphragm up here and your stomach down here. And then that other video, it looked like that lap band just zipped right around the stomach, but it doesn't really happen like that. We have to make a place for it. So we use a little electricity, make a little place for that band to go around the stomach. So that was on the left side of the stomach over there by the spleen. This is on the right side of the stomach over here by the liver. And you can see this liver is being held up by a retractor. And everything yellow is fat, of course. And so this fat is going to be pulled over, and right in front of this diaphragm muscle here is where that lap band is going to go. So we use this electrocautery, and we're going to make a little path right behind the stomach. And we're careful to dissect a very small path. We don't want this to be gaping wide, because we want that band to be snug back there. We don't want it to be moving around. And the instruments I use are a little different than the instruments they use in this video, but we basically accomplish the same thing. We get a path behind the stomach so that the band can be passed around the stomach. So as you see, the stomach is pulled down. And this device will be used to pull the band around the stomach. Another thing about this video, this is an old band. So the new bands look different from this, but the general technique of the operation is about the same. But we carefully place a band inside the stomach, and we bring that, carefully place a band inside the abdomen, bring it around the stomach, and then the band will fasten on itself just like a belt. So you see in the back, that band is in a nice little tunnel. It's not going to move around. But in the front, you may notice that there's nothing holding it in one place. So we do have to do a little bit of sewing on the front of the stomach to keep the band in the right place. So we take a little bit of stomach below the band, and we sew that to some stomach up above the band. And that gives you the right size pouch at the right location and holds the band in place. And you know, this video does not show the port being put in, which of course we take seriously as well. But this is the key portion of the operation. And you see how simple that is. There's been no GI tract cut, no stapling. And you could take that band off of this person and they would be exactly like they were before. It depends on what they are. You know, if you had a stomach operation, yes. But this is up kind of high, and usually your other operations, people would not have been in this neighborhood. Well, there you have it. So pretty much every time we get somebody here who loves to ask questions, I might have already found her today, but I encourage you guys to ask questions if you have some. Yeah. Yeah. The only operations that might be a deal breaker would be like if you've had a stomach operation, like a partial gastrectomy or like a Nissen fundoplication to prevent reflux. Those are things that could be a problem. Yeah, that's fine. Mm-hmm. That's okay. The port does stay in, yes, because you might need to adjust it later on. And the port is just part of the functionality of the band.
Like getting your medical report, would you have to go up to your doctor and get it, or do we come to the office and y'all will send up and they will send them down?
It's helpful if you can bring it with you. Yeah, if you can just get them to give it to you before. If you need some help getting it, that's fine, but while you're waiting to come in to see me, you could probably get that stuff taken care of. Oh, yeah. Have a question? Okay. That's a really good question, and it depends on how much your skin has been stretched, how old you are, like how much elasticity you still have in your skin. And so some people can lose weight and their skin still has some elasticity to it and it will actually go back some. Some people have been too big, their skin's been stretched too much, and it won't be able to go all the way back. So, there are some people who might want something like that. And it depends on the final, result that you're looking for, too. So, but yeah, it goes both ways, Some people need something done. I would say most of my patients don't, but, some of them do. Now, this does not compromise your immunity at all. Yeah. Well, for me personally, I'm not going to probably do this operation on somebody below 18, and there's not an absolute age limit. Were you talking younger or older? Younger? Well, it's probably younger than 18, for me. from an insurance standpoint, I think they don't really want to cover it at that. Now, if a 17-year-old was going to pay cash for it, I would have a totally clean conscience doing that, because this is, like I said, it's not a gastric bypass. It's adjustable. But you got to make sure also that somebody's mature enough to make this thing work for them, And from an older standpoint, it's a bit relative. If you've got some years left, you can make your life a whole lot better in 1 year with this operation, and help your medical problems a whole lot. So there may be somebody who came in that I said, it's really not for you, but most people, I give them the benefit of the doubt. Good questions.
Have you ever had anyone reach their weight limit and wanted to have it removed?
No. That's a good question, too. That brings up a good point also, because as I mentioned earlier in the talk, if you do something temporarily to lose weight, then your results are going to be temporary. So let's say you did lose if you wanted to lose 100 pounds and you lost 100 pounds and then your doctor took that out, you would say, oh my gosh, I am starving, I want food. And you would eat and you'd gain it back. Yeah. So we expect it to be there indefinitely. That's a very good question, though. Another one?
Can you feel it? You won't be able to.
You can't feel it. Now, the port is on top of your muscle. So if you're like, in the kitchen, you walk around the counter and you cut the counter like that, you might feel that port in there. In most instances, you won't. But if you lose enough weight and you run into something just right, you'll feel it. It won't necessarily be painful, but you'll be aware of it. But most people do not report, being aware of their band at all.
Could the surgery impede or possibly interfere with any emergency surgery or something you might not be aware of in the future?
The only thing I can think of is if you were to have like a bowel obstruction or something like that, and you need a nasogastric tube to be put down, it might be more difficult to get that tube down to go through the band into the stomach. That would be very uncommon for that to occur, but that's the only thing right offhand that I can think of. And to remedy that, your surgeon or somebody would need to take the fluid out of the band, and it would be open, and then your tube would go right down.
More than often, it would only be used if it was an emergency situation.
Well, I'm still, I'm having trouble thinking of a specific instance where it would be, a major problem. Well, guys, thank you for coming. Thank you very much. I'm glad y'all came. I hope you got something out of it. Like I said, Donna and Brittany here, and be happy to take your calls this week.
You have Blue Cross, you still need to go ahead and call them, or do you need to do your 6 months doctor?
I would recommend that you see me before you do the 6 month. And the reason is, when you're doing that 6 month, when you get the documentation done, you can send it to us as you go along, and we'll make sure that it's being done right. Because it's dreadful, like if you do 6 months with somebody, and then you hand it all to me, and I say, your doctor didn't say anything about behavior modification for 6 months, and then maybe they could remedy that, maybe not. I have had people in the distant past get through a 6 month physician supervised diet and find out they couldn't use it. That was very frustrating. All right. Y'all have a good night. Okay, one more.
How can you tell your BMI?
Okay, you can Google BMI calculator, and you can put your height and your weight in there. Or in the brochure that you got, you can also look at your, there's a form in there, there's a chart. And you can put your height and run your weight together and it'll give you the number.